Hello, I'm Dr. Alana Morris on behalf of CME Outfitters. Welcome to this CMEOCast titled Managing Patients with HFrEF Post-Discharge, Discussion of the Latest Evidence. This is the first podcast in a two-part series and is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. This activity is supported by an educational grant from Merck, Sharp, and Dome Corporation. Again, I'm Dr. Alana Morris. I'm an associate professor of medicine in the Division of Cardiology at Emory University School of Medicine and director of heart failure research at the Emory University Clinical Cardiovascular Research Institute in Atlanta, Georgia. And I'm very pleased to be joined today by Dr. Javed Butler, the Patrick H. Lehan Chair in Cardiovascular Research, professor and chairman in the Department of Medicine, and professor of physiology and biophysics at the University of Mississippi Medical Center in Jackson, Mississippi. Welcome, Dr. Butler.
Great to be with you, Alana.
Let's begin by reviewing our two learning objectives. After participating in this activity, learners should be better able to integrate a risk stratification tool into practice for assessing patients with HFrEF. Learning objective 2 is to implement treatment strategies for HFrEF that reflect updated guidelines and study results. While there are several recognized subtypes of heart failure, today we're going to focus primarily on heart failure with reduced ejection fraction, also called HFrEF, as significant progress is being made in this area as it pertains to both medical and device therapies, although we'll spend the bulk of our time today talking about medical therapies. It's important to recognize, again, the EF cutoffs for these categories, with HFrEF being an EF less than or equal to 40%, HFpEF being an EF greater than or equal to 50%. And we do now have this category of HFmrEF, if you will, an EF of 40 to 49%. This acronym was recently changed to denote heart failure with mildly reduced ejection fraction, previously called mid-range ejection fraction. And of course, we know that the Universal Definition of Heart Failure document was also published this year, and we have to think about these various stages, which of course have been sort of modified somewhat, but we have to think about patients who were at high risk for the development of heart failure based on some of the comorbidities, as well as patients who have evidence of structural heart disease but don't yet have signs or symptoms of heart failure, again, based on the ACC-AHA stages, as we know, or these patients who are now called sort of at risk or pre-heart failure based on this new universal definition of document. Of course, I think today we'll spend the bulk of our time talking about those who have current symptoms of heart failure. Dr. Butler, we know that the clinical course of heart failure can be relapsing and remitting, and for some patients become really refractory and persistent. Can you sort of describe this in a nutshell? I think this graphic is so important for clinicians to understand.
Yeah, so let's look at the natural history of sort of any adult with risk factors, right? So you have hypertension, diabetes, whatever you have, but you don't have heart failure. You don't have the syndrome of heart failure. You don't have symptoms. And over time, your kind of risk factors, you live with them for some time, your risk for heart failure goes up, and then you develop heart failure. So at that time, your risk is pretty high because now you have developed heart failure. Doesn't matter whether it's because of coronary disease or postpartum or chemotherapy induced, whatever it is. Your risk is pretty high because you now have heart failure and you're on no treatment. Then you start getting treated with a standard of care therapy and your risk comes down. But remember that the risk comes down, but it never goes down to what it used to be without heart failure. But there could be substantial mitigation of the risk. And that's why guideline-driven medical therapy is critically important in these patients. So then you have this sort of period of stability of symptoms, still residual risk, still we need to find newer therapies, but there is some degree of stability that could last for 6 months or 6 years. There's a lot of variability between patients, but then you start breaking through. So in other words, whatever therapy was keeping you stable, that is not enough. The biology is perturbed, the heart, the body is asking for more therapy. So this is something we call worsening heart failure. Now, traditionally, we had equated worsening heart failure with hospitalizations for heart failure because when people did break through their stable medical regimen and were developing symptoms and congestion, we would hospitalize them. But we have also realized that this worsening heart failure is also a biological issue, not the venue of care, because more and more patients are being treated with outpatient IV diuretics. So right now, the definition has been broadened to either requiring hospitalization or outpatient IV diuretic. But the important thing to consider is that right now, these patients are asking, their physiology is asking for more risk-modifying agents, and diuretics is not enough. Just giving them fluid medications and discharging them from the hospital, they will come right back. They're at a particularly high risk. And the reason why this worsening heart failure group is really important is that if we can optimize their medical regimen and do whatever we can pull them back into that category of sort of the outpatient stable heart failure. Because if we don't do that, then they progress to advanced heart failure, and then they become refractory to therapy. And now we're talking about things like transplant and LVADs, and if they are not candidates for that, then palliative care. So focusing on this worsening heart failure population becomes really important.
Absolutely. And I think you said something earlier that's really key that I think that we struggle with as clinicians, which is, again, even in these patients who appear to be clinically stable, even that can be a misnomer and can make our jobs as clinicians very tricky, and can make life very tricky for patients because they appear to be clinically stable. And some of those patients will have sudden death, as we see in this figure. And so, as you mentioned, sort of really emphasizing and titrating these disease modifying therapies is so key.
So it's a very subtle nuance, but I think we really need to differentiate. There is no such thing as a stable heart failure. These people are at a high risk no matter what their symptom is. Remember, we will never leave a person with systolic blood pressure of 180 or hemoglobin A1C of 10 alone because they are stable. There's no such thing. You have to treat to target. But there is such a thing as a stabilized symptoms.
Yeah.
So yes, optimize therapy, stabilize their symptoms, follow an optimal medical therapy, and when that is not enough, then reach out for other options.
Fantastic. So now that we've set the stage, let's specifically look at objective 1, which is to integrate a risk stratification tool into practice for assessment of patients with HFrEF. So this is a diagnostic algorithm that really comes from the new guidelines, the new ESC guidelines that were recently published. Dr. Butler, I know that you sat on this writing group. So if you will, please take us through the rationale for this algorithm and what clinicians should be thinking when we see a patient with suspected heart failure in clinical practice. What are the steps, how we should use natriuretic peptides, imaging, and other tools?
Yeah, so it's again sort of very simple, very sort of clinically relevant, some things that we do all the time. I would rather take the time to emphasize the timeline in which we do these things rather than what we do. So bottom line is, if a person presents with symptoms, shortness of breath, fatigue, tiredness, or the common symptoms that patients with heart failure present with, to suspect heart failure. This is the biggest thing, is to suspect heart failure. And I'll come to that again in a second. But then basically, check the natriuretic peptide. If the natriuretic peptide levels are elevated, go ahead and do some imaging testing. And if the ejection fraction is low, you got your diagnosis, heart failure with reduced ejection fraction. If the ejection fraction is normal, then you still have this issue of heart failure with preserved ejection fraction. So then you have to look a little bit deeper into the structural and the functional abnormalities despite of normal ejection fraction. The really important thing to mention here is, though, that the number one place where heart failure gets diagnosed is unfortunately in the emergency room. And the reason for that is that the diagnosis of heart failure is just delayed and ignored in the outpatient setting for a long time. And when people present with shortness of breath or tiredness or fatigue, because these are non-specific symptoms, the clinicians, appropriately so, they will check out for thyroid function, check out for anemia, check out for asthma, check out for COPD. But when those diagnoses don't pan out, we have this tendency to blame it on aging or obesity, not realizing that 6 months ago, the person was equally old and was equally overweight. So something has changed. But for whatever reason, we don't do natriuretic peptides, we don't do an echocardiogram, we don't diagnose, and it just keeps prolonging until a person gets really in extremis congested and come to the emergency room. So again, think about natriuretic peptide, think about echocardiography. Both of them are very simple. If you need to refer the patient, you can refer the patient. But the biggest thing is suspect heart failure.
Absolutely. And I think, there are certain populations, of course, where natriuretic peptides may not be as reliable. For example, obese patients with HFpEF. So again, that clinical suspicion that this may be heart failure is really key. And if you feel really concerned that that's the diagnosis, to keep searching so that we can really end up with that diagnosis to help treat the patient.
Completely agree.
What about some of these risk stratification tools that are available to us to, again, sort of help assign risk to patients? We can use some of these tools in various scenarios. For example, the Get With The Guidelines heart failure risk score we can use to assess in-hospital mortality for patients. The Seattle heart failure model, tried and true, we can use to project survival at baseline and after various interventions related to medical therapies, devices, and of course the ACC Treat Heart Failure app was developed to help manage patients with heart failure. And this is a really cool app. I love this because it allows you to really sort of tailor therapy for your individual patient at the time that you're seeing them. It provides sort of individualized guidance on the use of modern therapies for HFrEF and gives you really detailed information to allow you to sort of initiate and titrate and monitor these therapies. Do you use these in your clinical practice?
Yeah, so the ACC app is really sort of very helpful because it will, you just put in your patient information. It will give you sort of all the things that are maybe missing or that you can optimize. So that's sort of very helpful. When you talk about sort of the risk prediction models, obviously there is a ton of risk prediction models out there. Some of them a little bit more focused towards LVAD population, some about transplant eligibility, some in the inpatient setting. Most of them are derived in HFrEF population. The MAGIC score is derived in both HFrEF and HFpEF population. But I would again sort of go back to our colleagues. If you are in a heart failure transplant center, you're a heart failure physician, then I think all of these things really matter which tool you use. If you are a hospital administrator, then you might want to use a particular tool on the basis of which you will be judged for your risk-adjusted outcome. But for our clinicians that are out there, our nurse practitioners, primary care physicians, general cardiologists, the vast majority of the patients that are being treated, I think these are all common sense things. Kind of the blood pressure is slipping, the ejection fraction is slipping, the creatinine is kind of going up, the heart rate is kind of going up, and they are becoming a little bit more symptomatic. So yes, pick one. You can get a little bit more objective number. Remember that these are very good tools for populations, but not necessarily for individuals. At the end of the day, it's sort of your clinical gestalt and a good history physical will really help you go a long way.
Absolutely. So now let's move on to learning objective 2. We want to implement treatment strategies for HFrEF that reflect updated guidelines and study results. There are really so many options available for patients with HFrEF now. And I realize that there are so many device therapies actually that are available now. There are a number of drugs that we can see before us. Let's talk about, sort of how to implement some of these therapies. How do you think about utilizing these therapies in your clinical practice, Javed?
Yeah, so again, it's sort of really very simple, to sort of put them in 3 buckets, right? So you have the device bucket and the drug bucket. And the drug bucket can be divided into 2, your foundational therapies, and then your therapies that you reach out to if somebody is developing sort of more worsening heart failure symptoms. So at this point, there are sort of 4 foundational therapies. There are some options if some of the foundational therapies are not tolerated, then there are some backup therapies, like if somebody cannot tolerate a beta blocker, maybe you can think about ivabradine or something like that. And then there are some therapies like Verasiguac, for instance, that is specifically tested in patients with worsening heart failure. There are some therapies that are more targeted at comorbidities like ferric carboxymaltose for iron deficiency. And at the end of the day, if a person has an indication and medical therapy is not enough to have their heart recover to normal or near normal level, then there are obviously device opportunities available as well. But the bottom line is, first, give foundational therapy, assess their condition, and do that longitudinally, and reach out for more therapies if they are slipping on foundational therapy.
Absolutely. And again, I think that last point is key, that if patients are not doing well on foundational therapy, to refer, because of course we now know that some of those really advanced device therapies like LVAD, transplant, which used to have outcomes that weren't as good, really those outcomes have improved as well. And that's what your friendly heart failure clinicians are here for. Let's talk about Sglt2 inhibitors, for example. We know that there is just a wide array of data available to us now for the use of Sglt2 inhibitors in high-risk patients with diabetes. But of course, now we have evidence for efficacy for Sglt2 inhibitors in patients with HFrEF, with and without diabetes, and now, as of a few weeks ago, patients with HFpEF, excitingly. So tell us about some of the data with Sglt2 inhibitors and what we should be thinking with these drugs.
Yeah, so a couple of comments. So first is that as cliche as it is, what I'm about to say, the best treatment of heart failure is prevention of heart failure. And the beauty about Sglt2 inhibitors is that in patients with diabetes, regardless whether you have atherosclerotic cardiovascular disease or not, if you look at the plethora of trials that have occurred in patients with type 2 diabetes and Sglt2 inhibitors, there are differences in MACE outcomes and there are differences in cardiovascular mortality, but one consistent result, not only the result by itself, but even the magnitude of the result, about 30% or so relative risk reduction in development of heart failure is very impressive. So if you have type 2 diabetic patient out there, giving an Sglt2 inhibitor will prevent heart failure. So that's one comment. The second comment is that slowly we are now even getting data for prevention of heart failure without diabetes. So that's what we learn in DAPA-CKD, the CKD population, large proportion of non-diabetic patients. And in those, hospitalizations for heart failure was also prevented. But we are right now focusing on patients with stage C or manifest heart failure. They already have heart failure. So again, as you mentioned, 2 trials, DAPA-HF and EMPEROR-Reduce, showed improvement in cardiovascular death, heart failure, hospitalization, and now EMPEROR-Preserved in HFpEF patients as well. And then remember, soloist trial as well with the SGLT1, SGLT2 inhibitor. A little bit of a niche population, only diabetic worsening heart failure population, but again, consistent benefit was seen. The beauty about SGLT2 inhibitor is that all the reasons for which we are kind of hampered giving other medications like blood pressure and creatinine and potassium and heart rate and all that kind of stuff, that's really not much of an issue with SGLT2 inhibitor. You'll get a little bit of a dip in GFR when you start because of intraglomerular hemodynamic effect. But it's basically one dose, no dose titration. At this point, we have data across the spectrum of ejection fraction, HFrEF or HFpEF, and very well tolerated. So these are the advantages, and these are the new data for SGLT2 inhibitors.
Fantastic. I think there's another new kid on the block, which would be Verasiguac, which again was sort of recently included in the European guidelines, which were just released, which give Verasiguac a class 2B level of evidence B that tell us that we can consider Verasiguac for patients who are NYHA 2 through 4, who've had worsening heart failure, which we've talked about, despite treatment with an ACE or an Arnie, a beta blocker, and a mineralocorticoid corticoid receptor antagonist, to reduce the risk of CV mortality or hospitalization from heart failure. This is a novel agent. Tell us a little bit about this agent and again, how we might incorporate this into our clinical practice.
Yeah, so there are 2 things novel about Verasiguac. The first is that it's a novel mechanism of action, the SGC soluble guanylate cyclase stimulation. So this is completely sort of prevalent all over the body and is associated with nitric oxide signaling and CGMP PKG signaling. So it's really very prevalent and pervasive all over the body. And in patients with heart failure, where there is a reduction in nitric oxide bioavailability and oxidative stress, that is what this is targeting. The second novel thing about this is that unlike all the heart failure trials that we have done in patients with chronic heart failure, this really took on these patients that are at higher risk. That remember when we were talking about worsening heart failure and that they are at that point that if you don't change the biology of the disease, that they will progress to advanced heart failure and that we need to pull them back into that stabilized condition. That's where that population was tested. So patients who were either hospitalized within the past 6 months, including if you're in the hospital right now, or requiring outpatient IV diuretics in the past 3 months. So really focusing on biology of worsening and not just the venue of care per se. And in those patients, large trial, 5,000 patients, when Verasiguac was given on top of really good baseline medical therapy, we're talking about like 90+% RAS inhibitor, 90+% beta blocker, and 70+% MRA use. On top of that, there was a 10% relative risk reduction in cardiovascular death, heart failure, hospitalization. But remember that this is an incredibly high-risk population. So for instance, we mentioned the two Sglt2 inhibitor trial. Their placebo one-year event rate was about 15, 18, 20%. In Verasiguac trial, Victoria trial, it was 37%, more than double that of, say, DAPA HF, so very high-risk group. So that 10% relative risk reduction translated into a 4.2% absolute risk reduction. So really big absolute risk reduction. And I do want to make that nuance a little bit visible.
Fantastic. What about the Arnie compound? Of course, sacubitril/valsartan has been around for a while, so I think many of us feel comfortable. However, there may be some clinicians in practice who don't feel comfortable. Familiarity with the Paradigm trial, but of course, since Paradigm was published, we have Pioneer that gave us data in patients who had acute heart failure, many of which whom had de novo heart failure at the time that they were started on sacubitril/valsartan. We now have data from PROVE-HF, which sort of showed the effect on reverse remodeling with this compound. So give us a little bit of insight into sort of the effects of sacubitril/valsartan for patients with heart failure.
Yeah, so as you mentioned with Paradigm HF, we know that there's a substantial improvement in cardiovascular and heart failure, cardiovascular mortality and heart failure hospitalization risk, and certain cardiac death risk. 8,000 patient trial. We know that now for 4 or 5 years. But then it was tested in the Pioneer HF trial. Now, the primary endpoint for Pioneer HF was a biomarker change in NT-proBNP. But even in a short trial, just an 8-week trial, there was a substantial reduction, over 40% relative risk reduction in heart failure hospitalization rate, recurrent heart failure hospitalization. So it extends what we knew from Paradigm HF to hospitalized patients, patients who are naive to RAS inhibitors and are de novo heart failure. So you can just go ahead and start the therapy right away with an Arnie and not have to start first with an ACE inhibitor and then transition. So there was a lot of learning. And as you mentioned with PROVE-HF, we are now also seeing the significant reverse remodeling. And that reverse remodeling thing is really important. Although it was a single arm study, but even people who were on chronic RAS inhibitor and beta blocker therapy after switching, we saw in a significant proportion of patients, and we just published that in Circulation, that the reverse remodeling was such that they may actually not even require a defibrillator.
Wow, that's fantastic. You mentioned before iron deficiency anemia, which is extremely common in our patients with heart failure. And many of us, when we were in training, including myself, were sort of trained that IV iron was dangerous for a variety of reasons. But now we're seeing a whole host of clinical trials that are actually showing us not only the safety of IV iron, but the efficacy of IV iron in this patient population. Take us through some of that data, if you don't mind.
Yeah, so really simple. So, IV iron, the issue of the anaphylaxis in the past was related to the carrier molecule, not the IV iron per se. And that has changed. So that is not the concern right now. Now, there were, IV iron deficiency is a disease by itself. It doesn't have to be with anemia, because remember, it can cause shortness of breath, tiredness, fatigue, and worsening heart failure by 2 mechanisms. One, reduction of IV iron, reduction of serum iron leads to anemia, and that can cause it, so oxygen carrying capacity. But you also need iron in ATP generations in mitochondria as well, so irrespective of anemia. So we know for a long time, 50% of the patients with HFrEF have iron deficiency, and that these people are at worse prognosis and shortness of breath and fatigue. And now, for a good 10 years, we actually have 3 different trials that have shown that if you give IV iron replacement in iron deficient people, you make them feel better, they walk more, their shortness of breath and their quality of life symptoms get better, and their exercise capacity get better. But we did not have outcomes data in terms of the clinical outcomes. So that was actually tested in a 1,000-patient trial called AFFIRM-AHF. These were also worsening heart failure patients, but hospitalized heart failure patients. And in those patients, if they had iron deficiency by replacing IV iron, there was a 21% reduction in recurrent hospitalization risk over the next year.
So I'm inspired. You've given us so much data to really sort of inspire our use of all of these novel compounds to really improve morbidity and mortality for these high-risk patients. I think, though, it's important to sort of ground us for a second, because we realize from some really striking data from the CHAMP HF registry that unfortunately use of these agents is suboptimal. We know that many patients with heart failure in clinical practice, unfortunately, are not getting these drugs. Not only are they not receiving these drugs without a documented contraindication, there's also data to show that we're not titrating these drugs. Patients are sort of on them and they just are on them, without any attempt to increase the doses to the doses that we've used in clinical trials. Do you have any comment on that?
Yes, a quick comment. Good practice of medicine is a two-front war, right? So on one hand, you need to have evidence generation, novel therapies, but on the other hand is implementation as well. So I think we have so many good trials with positive data, but none of that will help our patients unless and until we implement that. So I would say that the implementation is really, really important. I mean, that goes without saying, but the speed at which we implement is also important. The biggest bang for your buck is when you introduce a new medication and block any particular pathway. Increasing the doses and going to optimal doses is incredibly important, but at least in the short term, 3-4 weeks period, on a weekly basis or whatnot, at least just cover all these abnormal pathways with the drugs that have been shown to modify outcomes. And then if you take some time to up titrate, that's okay. But it's important to cover all the abnormal pathways that promote progression of heart failure and do it in a timely manner.
Wonderful. Well, Dr. Butler, this has been an incredible discussion, but we're just about out of time. By way of summary, I'd like to offer a few SMART goals, which are specific, measurable, attainable, relevant, and timely action items that you can take back to your clinical practice. Use natriuretic peptides, including NT-proBNP or BNP, to diagnose HFrEF and inform prognosis. Apply clinical practice guidelines and tools to optimize risk stratification for HFrEF. Assess the current therapeutic armamentarium for HFrEF and evaluate the role of newer approved agents, and recognize the suboptimal use of guideline-directed medical therapy in practice and ensure that all patients with HFrEF receive appropriate therapies to improve outcomes. I'd like to thank you, Dr. Butler, for an insightful discussion today, and thank you, our audience, for joining us. I hope this information is helpful to our audience. Please follow the instructions on the web interface to receive CME credit. And don't miss our second episode in this series, Translating Data to Patient Care, a case study in HFrEF. Stay safe, everyone, and thank you again for joining us.